special guests. Yes. So, welcome to Talking Data Equity for Friday, April 24th. My name is Heather Kraus, and I'm the founder of an organization called We All Count. And the purpose of We All Count is to provide training and build and share tools that help anybody that's working on a data project align the way that they're actually doing the math, working with data, with their values and their priorities in the context of their projects. And as part of that, we host an ongoing speaker series. It happens most Fridays called Talking Data Equity. And you have successfully found your way here today. And the Zoom link for Talking Data Equity has been the same for 4.5 years now. So if you have found your way here, you can find your way back any Friday you want. You're always warmly welcome. It's a drop in, come as you are, come when you want kind of a scenario where we get to hear from people doing really cool work or have conversations about tools or try and work together to share resources and overcome challenges. And today we have an amazing special group that I'm going to introduce you to. And they are going to share with us some slides and some experiences. And as they do that, we ask that you keep your microphone turned off and use the Zoom chat. You can use the Zoom chat to share reflections, to ask questions. You can use the blue drop-down menu set to everyone, which means everybody here will be able to see your conversation. Or if you want to direct message me, you can use that plus button if you want to just talk to me. And then if we have time at the end, that's when you can turn your microphone on and do some live Q&A. So having been through oh yes, and I put in the chat the link to our Talking Data Equity schedule. You can always go there and see who's talking any week and decide if you want to come. And that's also a place where you can suggest speakers and suggest topics. We really try and make this something that is of interest to you. So tell us who you want to see, and we'll do our best to recruit them for a Friday. So let me introduce you to an amazing project and some amazing people working on the project. First of all, in no particular order other than the order in which I met them, we have Dr. Shawnika Hull. Shawnika Hull's scholarship, teaching, and service are situated at the intersection of communication, public health, and health psychology, with the goal of reducing health inequities through communication science. You can see how cool that is already. She applies communication as a tool to reduce health inequities through engaged scholarship that is focused on impacting individual, social, and structural causes of health inequities in HIV. Hull collaborates with community and clinical partners to understand the factors that impede HIV prevention, develop programs, intervention, and campaigns to address them. Continuing on in the order that I met these folks, we have Dr. Arlene Edwards, who is a community psychologist who recently retired from the CDC, where she served for 16 years as a behavioral scientist. And as a technical monitor, she assists in translating HIV prevention research into interventions for implementation in community settings. She pays primary attention on women and marginalized communities, and the work results in numerous reports, presentations, and publications. And Dr. Edwards currently serves as a consultant on the SISTA-P intervention, which you're going to hear about in just a second, while relaunching her nonprofit, is it the ELVA or ELVA?
The ELVA.
All right, the ELVA Collective. Next, I got to meet Jamila Ship, MPH. Ms. Ship has extensive experience in program development, implementation, research, and evaluation of HIV/AIDS prevention programs. And she specializes in underserved populations, particularly sex workers, homeless, and substance users. She has served as the chair of the California HIV Planning Group and holds a master's in public health from San Francisco State University and a BS in healthcare management from Florida Agricultural and Mechanical University. So thank you so much for joining us. And last but absolutely not least in any way, Ms. Dana Williams. Ms. Williams is the CEO and co-founder of the Community Wellness Project, which some of you might know as the CWP, bringing over 30 years of distinguished experience as a national and international public health consultant. Ms. Williams is a well recognized expert in HIV and AIDS prevention and care and has spent 2 decades as a lead master trainer for the CDC, advising technical monitors and training teams on the implementation of biomedical and behavioral interventions. And her work is defined by a commitment to data driven effectiveness and seamless adaptation of public health strategies across diverse global contexts. So you can see how lucky we are to have all 4 of these people in the same place at the same time. It was something of a miracle. And I'm going to turn it over to you folks. I believe Dr. Hull or Dr. Edwards will kick us off. And thank you so much, first of all, for doing the amazing work. And secondly, making time to come tell us about it.
Thank you so much for this really lovely introduction. And thanks to the team for co-presenting to this group. It's always delightful to see you. I'm going to do most of the talking for the presentation piece, but I hope that the audience will feel welcome to pull on any thread. We would love to talk about any aspect of the project, and that's why we're all here. Okay, so I'm just going to get into it. So in the big picture, HIV acquisitions are broadly speaking declining in the United States, but that's in response to the Ending the Epidemic initiative that is making strides towards eliminating HIV. But those strides are not equitably distributed. As you can see, Black women represent about 13-14% of the population, but we also represent almost half of HIV acquisitions. And among women, only 10% of women who could benefit from pre-exposure prophylaxis for HIV are accessing it. Pre-exposure prophylaxis for HIV is a medication that can be taken as a daily pill, or it can be delivered using a long-acting injection every couple of months. And now there's an FDA-approved version that's a couple times a year. And so this is a fast-moving innovation, and it is highly effective. But it's not being taken up at rates that align with need. In particular, women are dramatically underutilizing PrEP. And so we developed this project in response to that need. I want to give you a broad overview, and then we'll zoom in to the very particulars. The SISTA-P project is Sistas Informing Sistas about topics on AIDS and PrEP, was really born out of the recognition that these inequities are social and structural in nature, and that we have got to address women's needs in order to resonate with them and in order to improve PrEP uptake more equitably. And so we started this project with 3 broad aims. We sought to understand women's experiences and perspectives so that we could identify adaptations and updates to an existing HIV prevention intervention that was widely circulated, widely acceptable, but did not incorporate PrEP and was by far outdated. So we wanted to learn about the community and use that knowledge to update the SISTA program to address barriers to PrEP that are relevant to the lived experiences of Black women. We wanted to adapt SISTA, then implement those changes, and then pilot test to ensure that we were developing a program that resonates with people's needs, that's feasible to deliver, acceptable by the communities that we're serving, and that works. And so we conducted a series of theater tests to understand whether or not we were developing that kind of program. So we're going to dig into the specifics of those. But before we do, I want to sort of zoom back out just a little bit. Dr. Edwards?
Yes, so Sister P was informed by a huge community focus, primarily through really good formative research that was conducted predominantly by Dr. Hull and her team, and involved actually talking to Black women who were potential clients or candidates for participation in Sister P. So within that framework, three things that got pulled out is first, looking at the culture of Black women as a of course a subgroup of Black culture in general. So understanding who Black women are socially, and the idea here is to pay attention to the norms that tend to govern Black women's behavior in general and their behavior around maintaining and supporting the health of their communities. So the idea here was to be able to tap into that piece of Black women and their care for their communities and then extrapolate it to Black women's self care. So, what that allowed was for an easy transition between PrEP and some of the stigma that is associated with PrEP, tie in with the stats mentioned earlier regarding Black women and HIV, and then have a nice result of Black women community care extending to themselves as self care. So it provided a ready access or instrument that is readily accepted and known by Black women, and then that provided a good enough vehicle on which Sister P could sit. The second idea around context is really important with regard to Black women, where and how they live. And here we're looking at things like social determinants of health, geographic location, and how these come together to influence the how of Black women, how they live, and then how they do what's mentioned earlier with regard to cultural norms. So that understanding and the formative work that provided that understanding shows up in how Sister P is presented to Black women from the perspective of the theories that guide the intervention and how those flow into the activities that make up the components of the intervention. And then culture and context tie into the actual lived experiences of Black women. What are some aspects that influence self care? How do these emerge in that formative research? And then how is that data used again to define the activities that occur in Sister P? But then also, how is the process of Sister P reflecting the lived experiences of Black women so that feasibility and acceptability can become something that is not only studied and documented, but absolutely allows the lived experience to inform the data that is collected. So these are the things I think you will see emerge as the presentation continues and as you get a better understanding of the how and why of Sister P.
Thank you, Dr. Edwards.
You're welcome.
We wanted to produce a program with high levels of external validity and also high levels of internal validity. And we know that those two are have trade-offs. And so, but we really wanted to develop a program that had legs, that could be adopted widely and quickly, because there are over 750 agencies that were trained on the initial program, many of them trained by Ms. Williams and Ms. Ship. The initial program was beloved. And so we see this as a real opportunity to develop something that gets implemented on a large scale with without having to train up a whole force to deliver it. We would be poised to we wanted to be poised to update people's training so that they can adopt and we can move into implementation once we'd had established feasibility, acceptability, and effectiveness. So as toward the aim of increasing our external validity, we really and maximizing our ability to attribute any effects that we see to the program, we built the program in ways that are closely tied to four theoretical standpoints. In particular, we leaned very heavily on social cognitive theory because our aim was to collaborate with Black women to develop and maintain skills building around self-care in a reciprocal format that increases their efficacy regarding PrEP use and other HIV prevention activities. We wanted to encourage behavioral change that was progressive and inclusive of normed behaviors that support thoughts and actions for PrEP usage. We wanted to attend to the lived experiences of Black women and the social structural determinants of their health. And then we wanted to recognize and value the cultural and social norms that shape and support how and why Black women practice HIV prevention and self-care. And so we really leaned heavily on social cognitive theory, intersectionality framework, Black feminist, womanist theory, and stages of change. With regard to stages of change, we wanted to focus on the fact that behavior change is not dichotomous. People need to move through a progression of stages in order to arrive at actual behavioral adoption. And so we wanted to think about behavior on a continuum and support women along that continuum and also move them into the next phase of readiness. And so we set out with a plan. Our data collection timeline and program activities really centered on 3 phases. In phase 1, we conducted formative research with 30 Black women in Washington, D.C. in collaboration with the Women's Collective. And then those data were analyzed, and there were recommendations for adaptation that were then taken to an expert panel, which included Dr. Edwards, Ms. Williams, a medical doctor, and several other public health practitioners. Also, Ms. Knowles was on the committee, and a couple of her staff who work closely with the women that we serve. So the results from the formative work and the recommendations for adaptation were then taken to that group. And we had a very, very long and involved discussion about how those changes should be implemented, whether and where those changes should be implemented. And we used that to develop a first draft, which then we took to Atlanta and locked ourselves in a room and did a page-by-page refinement of that draft. And once we were satisfied with that draft, we set out to pilot test in 3 southern cities. We piloted in DC, Atlanta, and New Orleans in collaboration with Positive Impact Health Center, the Women's Collective, and St. John's Baptist Church number 5. And so through this process, we collected data around what are the reasons women are not using PrEP, and how are some ways that we could promote PrEP use. We incorporated that into the program and then tested it for feasibility and acceptability. And then we got some preliminary evidence around effectiveness. I'll just talk briefly about the results of the formative research. Several themes. We identified several very important themes. First was social emotional support. Commonly, women talked about trauma, mistreatment, mental health challenges. Women also talked about how they're managing everyone else's health and that self-care is important. Almost every respondent mentioned the desire to practice self-care and center self-care, but also the challenges doing that in light of obligations to our communities. I'm so busy caring for everyone else, there's no room for me to care for me. And so that really stood out to me. And I characterized that with the phrase, you can't pour from an empty cup. And so there were women who were doing self-care and who were very committed to it. And there were many women who wanted to engage in self-care and wanted to center their self-care, but really highlighted their struggles with doing that. And so the implications for SISTA-P is that we've got to incorporate emotional and instrumental support to help women center and prioritize their own health. And from this finding, we had this aha moment that was like, okay, SISTA-P should really be about self-care. And that's going to keep coming up. It was very prominent, and we followed that gut instinct. We found that women were largely unaware of PrEP. Many of the women who had heard of PrEP really didn't think of it as something that's for women. They've seen the ads on television and they assume that PrEP is for gay men and it's not relevant to their experiences. We also found that a lot of women talked about their PrEP would have been great for me back when. And as a sidebar, all of the women that were included in the formative work would be potentially eligible for PrEP, assuming that their labs came back, they would be eligible for PrEP. These are women who are living in an epidemic, a localized epidemic, and who are also reporting behavioral risk factors. So PrEP is relevant to everyone in the sample. And even so, many of the women were like, back then I really could have used it, but now I'm in recovery and I'm on my way. And now my circumstances are very different. And so that was really that tension between being possibly benefiting from PrEP, but not seeing that because of the relatively speaking, my risk is much lower than it used to be. And so in light of that, we hypothesize that a risk-focused approach is not going to resonate, but instead we should think about an empowerment approach because that would resonate with the desire to focus on self-care. And so we decided to take a broader view centering sexual health and health maintenance. And we also realized that we could try to more closely align perceptions of HIV vulnerability with the actual risk factors by talking about community level risk and talking about how you could be doing the same things in Lincoln, Nebraska, and your risk of acquiring HIV are going to be much lower just because there's less of it circulating in the community. And that really resonates. So thinking about pulling back a level of abstraction and thinking about HIV risk. But because this is so complex and because PrEP is rapidly innovating, right? During the life of this study, there were like 3 or 4 newly approved versions of PrEP delivery. And this is something that we're learning about late, and mistrust is high. And so scaffolding of knowledge and information about PrEP, about HIV prevention more broadly, is going to be really important so that when new innovations emerge, they fit into the framework that we've developed. And so we anticipate that that will cultivate trust and that will help people understand when there are innovations, how PrEP is relevant to me, what it's for, how it works, and then when innovations emerge, how those relate to what I already know. Partners come up quite often. We scientists often will rave about pre-exposure prophylaxis because it works if you take it like it's recommended, and you can do that autonomously and discreetly. You don't need to negotiate with your partner. And so this is the first woman-controlled version of HIV prevention. This is a game changer for us, except that it kind of is, because for women, PrEP is also very social, given our obligations to our partners and our communities. Many of the women that we talked to would not use PrEP discreetly and autonomously. They would tell their partner that they were using it, because not telling a partner about PrEP use is often equated with keeping secrets. It also doesn't help him at all. And what kind of partner would I be if we are facing HIV vulnerability? If I'm facing it, so are you. And if I'm using this medicine to protect myself and not telling you about it, then what kind of partner does that make me? And yet women still run the risk of being disclosed, even if they choose to be discreet, right? There are explanations of benefits, and there are multiple lab tests that need to be run. This is a medication that, has to be run through the pharmacy. So there are many opportunities for being outed for using PrEP, even if you don't want to be. And so we wanted to focus on how to navigate the complexities of partners and do that through using a health maintenance approach. Healthcare providers are another really important barrier. They're not talking to us about sexual health. They're not talking to us about HIV. And so in all likelihood, we're going to need to self-advocate with providers as well as partners. And SISTA-P could help here, help by training women with communication skills around self-advocacy and shared decision-making, by and in this way, women can generate and sustain these discussions with their healthcare providers and self-advocate with providers who are resistant. So that was the formative work. We use that to inform our thinking about how to adapt SISTA to incorporate SISTA-P. I'm not showing you the original version of SISTA, but if I did, it wouldn't look all that different. It's what's inside that's very different. And we have some of the names of the sessions have changed, but largely the names haven't changed, but the content is dramatically different. Insofar as we have developed a social skills training that attends to key aspects of Black women's lived experiences and with the aim of improving PrEP uptake as a form of self-care. So SISTA-P includes 4 sessions. Each session is 4 hours, 3 hours, and 2 boosters. The program is delivered by Black women expert facilitators, in our case, Ms. Ship and Ms. Williams. And SISTA-P is culturally and gender relevant and responds to Black women's lived experiences using skills practice, group discussions, lectures, role plays, videos, games, community discussion, you name it. We have a lot of fun. There is glitter. And so I'm happy to talk about what's in each of the sessions, but I hope that what you can see is that we're focused on centering self-care, building HIV knowledge, training women with communication skills, helping them manage decision-making, and then engaging in practice activities so that they can get feedback and guidance. Okay, and then the obvious question is, do people like it? Does it work? And we think that the answer is a resounding yes. We have a series of benchmarks for success. I'm kind of going to fly through them because I want to make sure we have enough room for questions. So here we go. Okay. We wanted to know, is SISTA-P feasible? Can we deliver it with fidelity? It is a scripted intervention. And so we want to make sure there's uniformity in terms of how we're delivering it so that we're sure that people are staying with SISTA-P as it was designed. Is it acceptable to participants? Is it well received? And how appropriate is SISTA-P to women's lived experiences? And so what we found was that SISTA-P is feasible. We recruited women in DC, St. Louis, and New Orleans. And what you'll see is the sample sizes for the number of women that we recruited for each session in the order of DC, Atlanta, New Orleans. What we were aiming for initially, we were aiming for like 12 to 15 per session. It became very obvious to us in the very beginning, that's way too big. So we cut back by far, and after the first session, we aimed for 6 to 8 per group. And we engaged in refinement between the groups. So we did a survey as a pretest. And then after each session, we delivered post-session questionnaires to try to understand what's working and what's not working in this session. Dr. Edwards and I sat in the back of the room and observed and vigorously took notes during every session. And then we would come together as a team and debrief after the session. I would take all of the notes, all of the recommendations, go back to the lab, refine the draft, and then take it back to the group, and we do another page by page review to ensure that the changes that need to be made that were reflected in the next iteration. We were quite pleased with the number of women that we were able to recruit and retain. I just want to remind you, each session is 6 weeks. So we did 4 days at 3 hours per day, and then we came back 6 weeks later, and then we came back 2 weeks later, and our retention was phenomenal. We kept almost everyone. I think we lost 1 person from pretest to follow-up. That in itself, I think, is evidence of SISTA-P's feasibility and acceptability. But what do I know? Okay, so what did we find? We were able to recruit women for whom SISTA-P is relevant, and these are women who across the age continuum. So, and we did not see during the sessions, women interacted very freely. And so we had women in their 20s all the way up to elders. And most of the women were single. Most had high school education, though the levels vary by city. Most women were in the, below 30,000 annual income, unemployed. Many were unemployed, particularly in DC and New Orleans. Almost everyone had health insurance, either public or private. And risk perceptions were relatively low on a 5-point scale. Only Atlanta reached the midpoint of the scale. None of the respondents had ever used PrEP, and very few had ever discussed PrEP with a partner. I think it's also very notable that very few had ever discussed PrEP with a healthcare provider, because as I mentioned, everyone involved is eligible, assuming their labs are good. Okay. The sample also behaviorally is somewhat vulnerable to HIV acquisition. And so these data are designed to show that we are reaching the population that we're serving, that we're not pilot testing in a sample of college students, right? Like these are the women who would be receiving SISTA-P in the real world. And we found that women really liked the program. So what you'll see at the bottom of this slide are the questions that we asked women. These are the results of the post-session questionnaire. So not every question was included in each session. So for instance, session 1 was about self-pride and self-care. So we asked women, do you feel more self-pride as a Black woman? Only in that session. Only in that city. Wait, I just misspoke. Only in that session. That's what I meant to say. And what you can see is that these are 10-point scales. People were pretty satisfied with the content. I have been a researcher for over 20 years. I have never had a measure that has no standard deviation. And yet Dana and Jamila come into my life, and then we have 1 no standard deviation, everyone loves it. 2 no standard deviation, everyone loves it. This is wild to me. But this is, I think, this is reflective of the fact that we were careful in building it and careful in delivering it, and we have the master trainers delivering it as we planned. And so we were very happy with these data with regard to acceptability. And they loved the facilitators. What can I say? So do I. And we were interested in preliminary evidence around effectiveness. We're not powered to test for effects, but we thought we have the data, so let's take a peek. These are not, we do have pre-test, post-test data, but I'm too scared to run that test just yet. But what we can see is that over the life of the program, women started at, this is a stages of change measure, and people were around 2.5 at the beginning of the program. By the end, we're at 2.9. I have not run statistical tests for significance in those differences. I feel good about the measures that ask people in relation to the session, have you made positive changes in your life? And we can see that a large proportion of women report making changes in their life as a result of the last week's session. And then when we ask women what kinds of changes they made, they're giving us the language that we're giving to them. So taking out time for me, I'm going to do PrEP. I'm telling people about PrEP. I'm going to do more self-care. I'm going to start doing self-care. I'm going to learn more about PrEP. These are all very closely tied to the lesson plan. And so we feel pretty good about that. In particular, over 70% of the sample said that they made changes as a result of the previous session. This is just a word cloud, but to my previous point, the kinds of things that women are saying in terms of the kinds of positive changes they made, some women are making appointments, some women are doing self-care, PrEP comes up over and over and over, partners come up, assertiveness. We have a whole module on assertiveness skills training, communication, understanding, perceptions, talks, positive, like taking positive steps, these kinds of things. But the point here is that these are aligned with the sessions that we delivered in the preceding weeks. And when we asked people what they liked about SISTA, They love the interaction. They love the discussion, the communication training, the feedback. Frankly, these are women whose healthcare providers are not talking to them about their sexual health. I don't know if you can see it in the background, but the uterus that we use is over my right shoulder. Like by the time we're done, we have given, physiology 101 all the way up through epidemiology 101. I mean, really, it's a very thorough discussion of what what happens with your body. What do you want to do with your body, and thinking about negotiating what your wants are and what your desires are. And I don't think that that's a conversation that many of these women have had. And so that was a really important part, I think, of SISTA-P when it comes to effectiveness as well as retention. When we asked women what we could do to improve SISTA-P, the answer was, can we have more? And I love that. And I think that that is a good place for us to pause and invite questions from the audience. So I want to acknowledge my partners, and I want to acknowledge our other collaborators. This very much took an entire village. And also it took commitment outside of our professional roles. I mean,
Yeah.
we haven't discussed this, but I'm going to say it out loud. Dr. Edwards, Ms. Williams, and Ms. Ship took more than a 50% pay cut to do this project with me because they are committed to it. And they said yes from the outset and didn't ask how much are they going to get paid, and didn't ask when are they going to get paid, even though the university takes a whole month of Sundays to pay. And so this was a labor of love. It took a lot of collaboration and it took a lot of goodwill. And I just wanted to acknowledge that. And I also need to acknowledge the National Institutes of Health who paid for it. That's it. Thank you.
Well, thank you so much for the presentation. And we really, hopefully, you can see the reaction on the screen, the hearts, the clapping hands. And we really want to send that back to you, that we know that this is way more than like your formal, professional job, and that doing a program like this takes so much time, so much energy, so much commitment. And to hear that you're doing it at a 50% pay cut is even more amazing at a time like this. So thank you so, so much for doing
Thank
this
you.
work.
Thank you for giving us this opportunity. Yeah.
Anytime. Come back when you do the next round of analyses. We'll have you back. And I don't want to take up too much time because I want to give space to the room. There are lots of questions in the chat that we can take, but I really want to give anybody who's here in the room live with us a chance to ask a question or share a reflection in person. I know there are people here who saw the names of who was going to be presenting today and came specifically to talk to you folks. So if you're in the room and you want to ask a question or share a reflection, if you can see your Zoom reactions and see how to raise your hand, you can do that. But if you can't figure out how to raise your Zoom hand, just turn your microphone on and share. That's totally fine. So while the people in the room are deciding if they want to ask a question or share a reflection, I will amplify some of them from the chat. And I'll try and find some that a lot of people have asked. First of all, there's just so much love for you all in the chat. So if you're not reading the chat, I hope you will after this. And there's just so much appreciation, and somebody saying that they were told to kind of contact you 10 years ago, and here you are doing amazing work still. So one of the really common questions that a couple of people are asking in the chat is, what do you think the pros and cons are of scaling up are? Now, if you don't want to answer a scaling up question, you don't have to, because I know that that might not even be a success criteria. It may not be even something that you think would be good for your program. So I just want to also mention that scale is not always inherently good, even though funders love scale. That does not mean that scale is good. So
Yeah.
what are your thoughts on scale, or is the non-scale part of the magic?
I am going to very briefly answer this, and then I'm going to ping it to my colleagues because they have far more experience than I do with this piece. The goal is scale. from day one, the goal was scale because this is desperately needed. We don't have anything in the compendium that serves Black. There is a compendium of evidence-based interventions for HIV and best practices for HIV prevention. We have my another research team that I work with. We have a structural intervention in that compendium, but there are no, and that structural intervention is designed to meet the needs of Black women, but there are no interventions in that compendium that are specific to the needs of Black women. And we want this. And so actually everyone else on the team has more experience with scaling up than I do. So I'll let them speak.
Yeah, I'll just contribute. I actually was the last technical monitor assigned to the original sister. So, and for me, as my introduction was, I was responsible for helping this original piece of research become a community implemented intervention. And Dana Williams, I when I joined CDC, was already on sister. So yes, the goal is scaling up and being able to implement SISTA-P as an evidence-based intervention, because there are projects that focus on Black women in PrEP, but there are no interventions. And one of the reasons is because it takes a lot of work to get the research done and then get the translation done and then get the intervention diffused throughout different communities. And I commend Dr. Hull amazingly for doing this level of formative work, because it is not typical. So what happens is later down the line, well, back when I worked at CDC, we start looking for this type of information to be able to augment the intervention as it's being diffused, because invariably you get different communities, different contexts, different cultures, and you have to be able to pay attention to aspects within those to get the intervention to be acceptable even after it's feasible. So this is a massive foundation for this intervention to be sitting on. So yes, the hope is for an RCT to be able to get it diffused as an evidence-based intervention.
So if any of y'all have $1.2 million, I'll take it.
You never know. You never know who might be on a call that has $1.2 million around.
Well, and I do think that the funding environment is changing. So the question is, we know what we want to do. How are we going to get there? And we have one piece of this is getting the publications out. So getting the project built was a lift.
Right.
And now these data have to find their way to light so that CDC can find them, so that we have established in print through peer review that the science is sound. And we think, everyone's looking at me because those manuscripts are sitting right here. I'm looking at them on my desk. But we think that that's going to be an important foundation for appealing to funders. I think Robert Wood Johnson has some really interesting mechanisms. But this funding environment, we were poised for an R01. We would have been very competitive. This project was funded through a K. And we were very poised for an R01, and that is not on the table anymore.
Right. Yeah. So for those of you who aren't familiar with health granting at the federal level in the United States, an R01 is a type of grant that is that this project would have been perfect for. That just isn't happening in the US right now.
We can't, I think it's worth saying out loud, all of our keywords are banned.
Right.
We can't submit a proposal because I can't write a bio sketch because it's just nonsense. It doesn't even read like a full sentence because so many of the words that I need to use are banned.
Right. Yep. And that definitely needs to be said out loud, and something that we do talk about a lot here. And yeah, not good.
I think this is relevant to the group because it's about, programmatic work that's aiming to really get at some of these deeply entrenched inequities. And I think, a project like this, there was a question in the chat about, did we pay participants? Not only did we pay participants, actually there was a question about retention and a question about paying participants. And I think they're deeply related.
Mm-hmm.
We treated our participants as the queens they are. We sent cars to their homes to come get them. I called and screened every person. I followed up with every person to ask, is she interested in participating? What are her needs? Does which time slots work? And we scheduled the sessions. In fact, when we were in New Orleans, we had scheduled a daytime session because that's what we had in DC. Our DC sample was not employed. Our New Orleans sample had, most of them had jobs. So at the last minute, we were switching the session to the end of the day to accommodate traffic and all the other things people need to do before their time is freed up.
Right.
So we built the program around what's working for them and what do they need. We treated them with dignity and respect and also love. We had beautiful, well, I wouldn't call it beautiful. We tried to have beautiful food. We ended up with Panera most of the time, but but we did try. So we fed people. I never invite folks into a 3 hour meeting without some food on the table. I ordered double the food we need so we could send people home with food. We
Mm-hmm.
paid people for their time as experts. So those
Yep.
interviews that we did, I think we paid people $100 each. And for each session, I think we paid $100. Plus, we provided personal transportation to and from the session so that they weren't carpooling or catching a train or
Yeah.
using a token. And I also think that having one coordinator who's not someone who's like hired after I was the person who was calling people. So
Right.
they came in the room, they knew who I was.
Mm-hmm.
They very quickly came to love the rest of the staff on the project. And I think that matters a lot, like a lot. I mean, there were a couple of people that I had to call after the fact because I missed a data point on them and I wanted to get it. And I could, they answer the phone for me. I think that matters for retention. That also has huge implications for the budget. Um, I was not able to pay my colleagues what the value of their work is, but I was able to pay my colleagues more than my colleagues are able to pay their colleagues, right? Like I'm
Right.
having to carve, we're all working with the same budgets, but we are
Right.
prioritizing that money differently. And
Yeah.
I think that all matters very much when it comes to retention. But then also, the funding mechanisms in the United States build on each other, the federal funding mechanisms. So, by establishing through the K, which is a funding mechanism, um, we poise ourselves for the next level up. So it's not just that
Right.
we can't apply for funding from NIH to support this, it's that I personally have put 15 years of
Right.
one foot in front of the other through this same funding mechanism to get myself in a position to get the funds we need when we have the big project.
Mm-hmm.
Because what we need to do next is a randomized controlled trial in order for this to be considered an evidence-based intervention.
Mm-hmm.
So that's
Mhm.
what our next steps are. We need to figure out, and we will figure out where to find the funding to pay for an RCT, because after that, it's go. And my colleagues can speak to the way the original SISTA took off. I anticipate SISTA-P will also be well received by community-based organizations, but we
Mm-hmm.
need the randomized controlled trial to get there.
Right. Well,
I
this
just
community will absolutely do what it wants. I want to make sure that everybody else, Jamila and Dana, if you want to share anything, that we have time for you.
Oh, I'll just share that one of the questions I saw in there about how is STD, sexual health incorporated in one of the sections. Well, throughout, I feel like when we were doing the trainings, it naturally comes up, but we also do go over STDs and sexual health, and we talk about healthy relationships and how those apply to you being empowered to talk about your own, you know sexual needs and all of that with your partner. And so oftentimes it naturally comes up around just kind of overall sexual health, and as other questions around STDs come up, because you'll be surprised how many women just don't know some of the certain things. So a lot of questions just spawn and come up. And, Dana and I have been doing this work for a while. And we did the original. I used to be a sister. I did the original sister too, so I
Mm-hmm.
already was prepared for people to be asking all types of questions, and so that usually comes up for folks. So.
Great. Thanks. Yeah, it makes a lot of sense. I mean, that's amazing. Meech, it's great to see you. Dana, we want to make sure that if there's anything you want to add, we have space for you.
No, thank you so much. This was a very exciting opportunity for us. I'm one of the co-authors of the original sister intervention and have been working with CDC for the last 15 or so years. I've co-written 7 interventions and worked with Dr. Edwards directly on 3 of the interventions. And so
Yeah.
this work was a labor of love. I do think it's important to note that, as Jamila has already shared, we've been doing this work together for a long time, and facilitation of this intervention is important, and the way in which you engage the women is important. That's part of what keeps the women coming back. And so we'll definitely have to look in more detail on how to train people when the opportunity comes to actually implement this intervention. But it's amazing to me how much this intervention is needed and
Mhm.
how important it is to realistically be able to work with these women who needed our information the most. So it's a
Yeah.
great opportunity. Thank you.
Well, thank you. And I think your evidence absolutely supports everything that the 4 of you have said. And the community here is clearly very impressed and very excited. And there are some very creative people here that will do some thinking because, of course, we want to see an RCT on this as well. And that old Sesame Street, like under, through, around, and behind or something. That's what we're all trying to figure out how to do right now. And so we'll leave it here for today because we want to respect everybody's time. But we'll absolutely stay in touch with all 4 of you and SISTA-P in general. And I really, on behalf of everyone here, want to express our sincere gratitude for clearly all the care and time and resources that you've already poured into this. And we'll find ways to be on your team to get to the next level,
Thank
because you
you.
absolutely are going there. It's just a matter of how and when.
Thank
All
you.
right.
All right. So we'll leave it there. And everybody take good care of yourselves. We're back next Friday with Dr. Lisa Bowleg, who you can see actually here, her logo on the Intersectionality Training Institute. And she'll talk to us about a framework that she's put together that will be hugely helpful to anybody doing intersectional work, which is a bunch of you. So take really good care of yourselves and each other. It can be rough sledding out there. So let's remember we're on the same team and act like it. All right. Bye, everybody.
Bye-bye.